up incident management systems and emergency operation centers, and also having rapid response teams. Country wealth was not a predictor of success. You can see, at least we saw this for the US. Vaccines were developed at a very unprecedented rate. I mean, this is probably the fastest chain of, from R&D to vaccines in people's arms. And then open data and open science collaboration were very good. People shared genome sequences, which was a good thing. So these are some of the lessons that we should learn from moving forward to prepare for the next pandemic. In terms of health systems, we really learned that pandemics like COVID-19 affect all the 4 interconnected health systems blocks. They affect access, physical, financial, socio-economic. Facilities were locked up, lockdowns, people couldn't access. But also health workers couldn't even go to the facility. But it also affects the quality of the services developed. I mean, there were disruptions in routine services. The demand capacity was also affected. I mean, if you look at most of Africa, which is the informal sector, people really, the informal trade which was affected, all these people out of pocket, they couldn't access health services. But big about this was really the resilience capacity, which is the ability to continue the delivery of essential services even in the presence of a shock event. But if you look at that functional health system that we published recently, anything that affects each of those actually affects resilience. So we should be thinking more broadly that resilience is, if you affect governance, you affect resilience. If you have a workforce strike, it is going to affect delivery of essential services. So it's going to affect resilience. So I think there is a new shift on how we define resilience. So, given those lessons learned, what are the 5 urgent policy actions? And we have been having some discussions at WHO Afro. The first is really to build emergency preparedness and response capacity. And this is really the work around the international health regulations, the ongoing discussions around the pandemic treaty or convention, we don't know what it is going to be called, issues around leadership, governance, equity, and systems, laboratory systems, surveillance systems, infection prevention, and any system that you can think about. But also, we need to build inherent resilience of the system itself, which is more investment and reorganization of existing resources and services. But also we need to build overall health system capacity. Those of you who know the traditional health system building blocks, this is really the whole issue around better investment in governance, both technical and political, human resources, infrastructure. And in terms of infrastructure, one of the issues around infrastructure, especially for contagions, is makeshift infrastructures. Those of you who are in Sierra Leone and Liberia, if you know the treatment centers there, they even had helipads. If you go there now, there are bushes. Well, we should be building infrastructure which is going to be sustainable and resilient. Is makeshift treatment centers for cholera, for Ebola, for yellow, I mean, they really are not sustainable, and we need to shift away from that. Having more model infrastructures to deal with the first few cases and then scale it up. We need to monitor continuity of services, definitely, not only to monitor the epidemic curves, but to monitor how services are being disrupted, whether EPI is being disrupted, whether malaria interventions are being disrupted, TB interventions are being disrupted, or delivery of ARVs. Actually, in a COVID pandemic, the first wards to suffer were mental health wards. They were repurposed to be isolation wards. And yet, as you'll see later, we need mental health experts. And then to test the availability of and the functionality of systems during peacetime. So, we've had some discussions around what do we track? Should we only be tracking health security, the international health regulations, the joint exam evaluations that we do? That alone could not predict response. We must be tracking other things. The resilience of the system, the shift towards UHC. So we shouldn't verticalize health security. I think there is a thinking that emergency preparedness is being verticalized with a lot of funding and leaving the other health systems. So we should be monitoring all this across the board. So in Africa, what are we doing moving forward? And we've come up with 3 initiatives, and we're saying, learning from COVID to prepare health security in Africa. But Why have I focused on Africa here? We have about 100 events every year. This is the WHO Africa region alone. We've had some lessons. The time to detect and control outbreaks, if you give and take and remove COVID, has dropped a bit. But COVID-19 has really showed us systems weaknesses across the continent, but not only in Africa, elsewhere. So we've come up with these 3 flagship initiatives, and we've given them some acronyms, and the first one is really to do with respond. And we've given it the acronym Support Utilization of Response Groups for Emergencies, SURGE. And that is really going to deal with all the response issues that we're talking about. And then the second, which is going to deal with detect, we are calling it Transforming Africa's Surveillance Systems. And the third, which is dealing with prepare, we're calling it Promoting Resilience of Systems for Emergencies. And I'll just quickly go through those in the next couple of slides. So this is the one I like most, which is on promoting resilience of systems. At the base, we have, and then these are the pillars around the surveillance structures, support countries to scale up, both especially electronic surveillance systems, and then data management and informatics, and then workforce development specifically for surveillance, and then advocacy and policy. The second is strengthening response groups. The third one, this is really the critical pillars are workforce development, response readiness, and coordination. You know, with preparedness, there is a gap between the emergency preparedness cycle. We need to be ready, both community readiness and facility readiness, and operational support and field logistics and risk communication and community engagement. These are the kind, for each country, we are really looking at establishing a team of SURGE, and this is just a generic kind of what kind of workforce we need. We've learned for risk communication and community engagement, we need anthropologists, we need social scientists. I was in Zambia during the SURGE Wave 3, and most of our health workers were depressed because they knew what to do. You want to give oxygen, high flow oxygen, but you don't have it. And we don't have mental health experts. That might require for us to be discussing with training institutions to see who is coming from the pre-service training curriculum for some orphan cadres. So this is what we want to do under SURGE. And for those 3 initiatives, there are 3 coordinating centers that we are establishing for now to support this work. They are based in all the regions of the country. In Senegal, we're going to set up a hub there to coordinate data, innovation, and epidemic intelligence. In Kenya, in Nairobi, we are setting up a workforce development and operational logistics hub. And in South Africa, we are a coordination center for R&D and genome sequencing. But these are centers to coordinate. Additionally, we'll have some other sub-hubs probably that are well established and collaborate with training institutions. For all this work, we really are focused on a multi-sectoral approach and collaborating with different stakeholders, academia, UN agencies, the private sector. And my RD one time said in Bali a couple of years ago that multi-sectoral collaboration is out of necessity. It's actually out of common sense. Nobody can protect the world, not a single sector, not a single agency. And so what we do must be complementary and synergistic. And so we need to know what everybody is doing. There is a role for academia, there is a role for research institutes, there is a role for ministries of health, there is a role for Ministry of Agriculture, Ministry of Environment. So to sum up really, from the H1N1 pandemic of 1918 to SARS in 2003, to the West Africa Ebola, 2013, 2016, and now the COVID pandemic. Epidemics and pandemics have had devastating impacts. We cannot predict with certainty which pathogen will cause the next pandemic, nor where it will occur, nor how dire the consequences will be. But if humans and infectious pathogens coexist, pandemics will continue to occur. And the only way to do that is for us to build capacity for health security, which is integrated with building resilient health systems for universal health care. That's the only avenue. And that's the end of my presentation, so I would like to thank you with this final slide. At the second International Conference on Re-Emerging and Infectious Disease in Addis Ababa in March 2019. I gave a talk there based on how we are prepared and how we assessed, because that talk was, are we prepared for the next pandemic? So at the end of that talk, I actually asked, are we prepared for the next pandemic? A couple of months later, COVID-19 shocked us, and we were not prepared. I think we need to act now to prepare the world for the next pandemic. So thank you very much. I have saved 5 minutes, so I would like to introduce to you something that is really, for us, shocked us. Is a scientist, and this is my regional director. This is an appeal. We are setting up, IT, if you could help me to run this. The regional director, in a 5-minute clip, we've set up a fund for a colleague of ours who succumbed to cancer in February this year. So, thank you. Sound.
Omar, volume, please. Omar, check the volume, please.
Greetings, colleagues and friends at the ASTMH. Greetings, colleagues.
Increase the volume.
At the ASTMH meeting in Seattle and around the world. I'm honored to be making this announcement regarding the opening of applications for a new program near to my heart.
Well, can you start it again?
Greetings, colleagues and friends at the ASTMH meeting in Seattle and around the world. I'm honored to be making this announcement regarding the opening of applications for a new program near to my heart and likely to many of you, the Mwele Malechela Mentorship Program for Women in NTDs, hosted by the WHO Regional Office for Africa. In February of this year, we lost one of Africa's most highly respected female scientists and the visionary behind the 2030 WHO roadmap for NTDs, when Dr. Mwele Malechela lost her battle with cancer. As most here will know, Mwele was the director of the WHO Department of Neglected Tropical Diseases Control at our headquarters in Geneva. As a cherished colleague, sister, and friend, she had before that served as the director of my Office of the Regional Director for Africa. She left a lasting legacy in the transformation of our work in the region. Prior to joining WHO, Mwele served as the Director General of the National Institute for Medical Research in the United Republic of Tanzania, the first woman to occupy this position, and as the founding director of the National Lymphatic Filariasis Elimination Program in Tanzania. Equally impactful to her esteemed career in global public health was Mwele's unique and sincere ability to touch individual lives, including inspiring other women in science. Anyone who knew Mwele knows that she had an indomitable, fierce fighting spirit for NTDs that was only matched by her genuine care for the fellow travelers who walked beside her while on this earth. Mwele gave freely of her time and talents to mentor and motivate the next generation of global health professionals, particularly women. This mentorship program is intended to keep her legacy alive, explicitly focused on African women living in African countries who work in the NTD sector. The Mwele Malechela Mentorship Program aims to help mid-career women scientists overcome barriers to realizing their potential and become leaders and champions of NTD elimination at home and internationally. I first announced the formation of this program at the Kigali Summit for NTDs and Malaria earlier this year, and now I'm pleased to announce that the inaugural call for applications will open in December. With the generosity of a long-term commitment from the Bill and Melinda Gates Foundation, the program will fittingly run through 2030 to honor Mwele's own commitment to the 2030 WHO NTD roadmap. Starting this year and continuing annually for the next 7 years, 5 women will be selected for this prestigious opportunity. They will each be matched one-to-one with a current global health leader for a structured mentorship program that will last for 2 years. Each woman will also be given a stipend of $15,000 that she can use for leadership training, skills building, and other career development opportunities. In addition to mentoring, the women will join an exclusive peer network of fellow high potential female leaders in NTDs, including women in their cohort and alumni of the program. I have committed to being personally engaged with this program, including being among the first mentors for it. I'm very pleased to share this program with you. Please visit the WHO Afro website, www.afro.who.int, by mid-December, and consider whether you or someone you know should apply for either a mentee or mentor role, and encourage them to do so. I'd also like to express my gratitude to our partners working together to make this program possible, including the ASTMH, the END Fund, and many other dear friends and colleagues of Mwele who have come together under the Friends of Mwele banner to honor her legacy. We are convinced this program will carry forward Mwele's legacy in a way that honors her lasting influence in our own lives and in the lives of so many people served by her work. She would have wanted nothing better. Thank you. Greetings, colleagues and friends.
Thank you very much for that. Ambrose, do come and see if there's any questions for you. Has anyone got any questions for Ambrose? Thank you for that talk. And I failed to acknowledge those people joining us online, and hello to them. They were very welcome indeed. Any questions for Ambrose? If not, I've got one, I can tell you that. One of the most notable things you said was that countries' wealth was not a predictor of success against COVID, and that was very stark, I think, and unusual, the extent of that. Could you try and summarize any particular reasons why you think that was true? That, on the whole, rich countries managed to do pretty badly?
I think for some it really was partly to disregard science and not believe in what the science was saying. But also I think we've looked at these health security indices and metrics which we assess, and most of the countries which are really wealthy, they have the best global health security scores, and some of these really didn't directly link to delivery of healthcare or experience in response. And so countries that really had experience in responding to outbreaks activated their systems very, very quickly from a coordination mechanism, both the political coordination mechanisms and the technical coordination mechanism and the response, and implemented initially. I think I am for non-pharmaceutical interventions for a short period, and then they implemented non-pharmaceutical interventions to the letter. The other is really the level of probably risk communication and community engagement that went across and how people perceived this. I think in places where outbreaks are common, the messaging was very quick and people really believed in the messages. But then in other places there were, if you look at issues around vaccine hesitancy, for example, in some of the developed countries, these were some of the issues. Even when there was a vaccine, there was vaccine hesitancy. So there are really several factors that one can think about. Thanks.
Thanks for that. Any other questions for Ambrose? Yes, Beata over there. You have to find a microphone, it'd be great.
Thank you. Ambrose, my question relates to the surveillance plans that you've nicely illustrated there. So, you know, I always worry that we have a lack of diagnostic tools. Can you hear me? No. Can you hear? Yeah, okay. You have elaborated very nicely on the plans for surveillance that will equip us better to anticipate which pathogens might be coming up and where we have to be prepared. But that really requires diagnostics. And these are diagnostics we not have at the sites where patients present. So what is the plan for rolling out more widely available diagnostics? Because this needs to be supported by the countries themselves, right? And I'd like to hear from you a little bit more how that is anticipated, because people will be happy to have no swabs, but they will be even more happy if they know what's wrong with them when they present with a fever to their healthcare center.
It was quite difficult to hear up here, but I think it was around diagnostics and particular expertise in using those diagnostics. Is that right?
I don't know. It would be good if people can actually hear the questions. Is that better? Can you hear now?
Yes.
At the front? Okay. My question related to the surveillance program that you have proposed, and I wonder how that feeds into the diagnostics that are going to have to be available at the site where patients and people with undiagnosed fever, etc., present, because it's not just any ordinary surveillance, you know, sentinel sites, etc. What people really want is to know what's wrong with them when they present in a health center, and that will give us the surveillance data that we need. And where does that feature in your plans?
I think that fits within the work around R&D on diagnostics and having point of care diagnostics. Because, as you know, CEPI, which was set up post-Ebola, the focus has really been mainly on therapeutics and vaccine. But there is a feeling within this that we really need diagnostics. And point of care diagnostics, there may be rapid diagnostic kits, but also to have that countries set up systems or national laboratory systems where we can transport samples from the most peripheral part of the country to a reference laboratory, either at the center or within at the district hospital. So there is ongoing work in our discussions. Because these projects, we were implementing them continent-wide with our colleagues at Africa CDC. And Africa CDC is driving something around regional manufacturing. I don't like the word local manufacturing because not everybody can have the capacity to do manufacturing, but this is one of the issues around regional manufacturing of some of the countermeasures that we require. Thank you.
Thank you for that. Umberto.
Thank you, Ambrose. Thanks. So you, Ambrose, you mentioned about teams at country level able to investigate a suspected epidemic. That's what I got from your presentation. You know, so. In terms of, you know, detection response. And I think you said that this team should be ready, you know, that. So I don't know how a team like this will be integrated into the whole system, and what this team would do in between epidemics. You know, I think it's a question of how this is going to work. And there is an issue about capacities, maintenance of that kind of level of alert over a certain variable periods of time. So how you maintain the sort of tension there, how this is integrated with the normal health system. Thank you.
Thank you very much, Humberto. I mean, this is, that has really been one of the questions we've been discussed, we've received when we presented, especially the surge component. We're reaching out to the countries and we're working with the countries to identify the expertise that we have already and have that in the database. We've had an initial discussion on what is the retention scheme we are going to have to keep them, especially in times when, in peacetime. When we have an outbreak, they will definitely be deployed and they can have activity-based kind of incentive schemes. But in peacetime, and we've been discussing some of these, we're trying out a couple of models. Some of them is use them for training. And then we've been, in the discussions we had with Bill and Melinda Gates, there will be some incentive scheme that we want to try out and look at it, and then try to sell this eventually to most of the governments after we have done like a proof of concept on retaining people, and then the governments then take on. But the issue is really to have a database of a multidisciplinary database. Depending on the size of the country, we are looking at the smallest country like the Gambia here, probably about 50 at national level, and alternates who can then be deployed within 24 to 48 hours. And so we would look within institutions in the Gambia, the universities, to see whether we have that expertise and people who can be deployed or people who can then train others. If the cadre is not available, then it's really to work with academic institutions to create, for example, I'll give you one area where we've seen there was a gap from COVID. If you look at most of our logisticians, they are repurposed storekeepers. So that is an orphan cadre. Mental health, we learned this from COVID. We don't have mental health experts. We need to be working with university to see that we churn out mental health experts. It's the same, I think, for many countries, anthropologists and social scientists, who we need to work with our communities and engage with the communities to ensure that our messaging is strict. We might actually need to go back to the drawing board to see that these people are being churned out by the training institutions like this one. Thank you.
Thank you, Ambrose. I think what we'll do is move on to Pontiano. So my honor to introduce Professor Pontiano Kalibu, who many will know is the director of MRC unit in Uganda, Entebbe, and also the director of Uganda Virus Research Institute. Pontiano, over to you, once we've got your slides sorted.
Okay. I don't know whether it is clear, audible. There was a lot of echo. Is it okay? Yeah, okay. Let me also, first of all, congratulate the MRC Gambia, the London School, on this 75th anniversary. You have really made a lot of contributions and which are being felt globally. My unit is very young, 34 years. I hope we shall reach 75 years and beyond, and also celebrate the 75 years. But otherwise, congratulations. I also thank you for inviting me to give this presentation on COVID-19 in Uganda, but also update you on the Ebola outbreak. And this is going to be the outline of my presentation. I'll talk about the pandemic, the vaccine uptake, the role of UVRI as a reference lab, and then I'll also give you some of the studies that have been conducted under the MRC and MRC UVRI London School unit, then Ebola outbreak, and a summary. I'd hoped, of course, the earlier speakers were going to say more about the COVID globally. I got this 2 days ago, that globally we have had about 640 million confirmed cases of COVID, including about 6.6 million deaths. Of this, 12.7 million cases from sub-Saharan Africa, and about 260,000 deaths, which are noticeably lower impact, especially the severity and death setting in in Africa compared to other countries. In Uganda, data that was collected by October 24th, we had registered about 170,000 COVID cases and about 3,630 deaths. But this is an underestimate. I think the recording and the reporting is the reporting of those who are PCR positive that have been diagnosed. But of course, if you do serology and antibodies, you realize that more people are really infected. So this must be a real underestimate, and I guess it is also globally. But the good thing is that since September 2020, there has not been registered any death in Uganda. We started from the time we identified the first case in March 2020. There was lockdown, and I think Uganda had the longest school closure. 2 years, children were not going to school. So there was some response. This is a curve, as you can see, like many other countries in Africa, 3 waves. The first wave, August 2020 to about January 2021. The second wave, May 2021 to around June 2021. And the last one towards the end of last year to January this year. And I'll say a little bit more about this in terms of the variants that we saw later on. In terms of one of the, what we have been looking at, and this was done by other colleagues at Uganda Virus Research Institute, is to look at disease severity, especially very early on in the pandemic. In summary, this study indicated that earlier on, disease severity was low in our setting. It was more, severity was more in the older age group. The numbers were not big enough to associate with some of the co-infections like TB and malaria. But in that bar graph, the dark shows that the number of cases initially in hospitals were mostly travelers. People who have traveled because a lot of our pandemic was initially among the travelers, and later we started seeing cases internally. And I think that's why there was a dominance of the severity of disease, and those who were hospitalized, they were largely male earlier on. And of course, during that follow-up, there was no death. So that also it indicates to you that the severity of disease has not changed much. It has not been a very severe disease in terms of death and mortality, and it's been more associated in the older age group. Vaccination has been key. That's our president receiving a vaccine. He was very an advocate of vaccination, but of course the challenge, the vaccines came late, and they gave room for hesitancy, those who are talking against vaccines, and that delay also eroded some of the confidence and the interest partly for vaccination. Our vaccination coverage is shown in this table, and is grouped into those who are 18 years and above, 12 to 17 years, and overall. Initially, our target was to vaccinate the most, those at risk, health workers with comorbidities, older age group, but later it was expanded. But as you can see, if you look at those at 18 years plus who have completed the primary series, only about 58%. We encourage people to get booster doses, but you can see those who have received booster doses are even lower. A few months ago, we expanded to include children 12 to 17 years. And as you can see, when you go and include all, the coverage is a little bit low. We should have expected a higher coverage. So vaccination, the vaccines are available, but the coverage, those who have received it have not reached the target. But of course, we talk about access. There are other challenges of access, getting these vaccines. From the very beginning, our institute was given a big responsibility to be a reference lab for COVID-19, evaluation of all the kits that come into the country, accrediting labs in the country, genome sequencing in the country, but also around. So a lot of work was done, and there was a lot of pressure, of course. Many people came up with kits. We evaluated them. Some of them were not as good, but there was a lot of work that went on as we prepared for this COVID. We also acted, our MRC lab acted as a regional reference lab, and this slide shows some of the work we did for the neighboring countries, but also worked very closely with many colleagues in Africa to look at the epidemic and pandemic. And again, what we saw was a lot of the earlier epidemic was introduced by the travelers, and even the variants that we have really reflected that introduction. I'd like now to turn to some of the completed and current COVID-19 activities in the MRC unit. I've talked a bit about diagnostics. I'll talk about surveillance. What you see in red is what I'm going to talk about. Genomic sequencing, immune profiling, vaccine hesitancy studies, vaccine development, and vaccine trials. And also I'll talk about, so that's the work within. From the beginning, through funding from the Medical Research Council, we conducted a surveillance study in one of our cohorts, the general population cohort, a very long cohort that about 20,000 individuals that are followed annually. And we looked at about 500 individuals in a population-based household, another 500 in an urban setting in Lukaya, a township nearby, to see the extent of the epidemic. As you can see this graph, what we saw in our cohort, the waves, is not very different from the picture I showed you earlier. There were more infections during those different waves. In this study, there were slightly more COVID cases in the clinic than in the household. 4 deaths were reported, and the risk increased with the age, but not with comorbidities. Serology was done and in the first wave, during the first wave, and in the serology, the first, what I showed you earlier, was based on PCR, those who are PCR positive, but this slide shows you that those individuals who were tested with antibodies. In the household, about 21% were seropositive, and the clinic, about 19% were seropositive. And 1 in 5 were infected in the first round. That was the first wave. We looked at associations with HIV, with other comorbidities, which we didn't find, but the major association was reactivation of the cancer-causing gamma herpes viruses, indicating that SARS-CoV infection could reactivate some of these viruses. But more work needs to be done. Another data that we collected was to look at mortality. Mortality data in Africa is lacking. There isn't a lot of mortality data, but we have an opportunity in this population to collect mortality data weekly and monthly. So what we did was to compare mortality that was seen between the years 2015 and 2019, and the mortality during the time of the COVID pandemic. And again, we did this over the 3 waves. What you can see, I think, just looking at closely, that there was no excess mortality that was seen during this period. So COVID did not lead to the excess mortality that was seen in other populations in other countries. We have also been very active looking at the sequencing of the virus as a reference lab, and here I've listed some of the sequences that have been registered in the GSAID, about 1,340, but I'm aware there's some that have not been deposited yet, and we have different labs that have been doing genotyping, and most of the genotyping has been done in the unit, and these have been deposited. And what we saw at the beginning, as I mentioned earlier, was that a lot of the variants, strains that we had, were matching those strains where these individuals came from. And that was one of the earlier publications, the main routes of entry and genomic diversity of SARS-CoV-2 in Uganda. So there was a lot of matching. But of course, this changed over time, and towards in June, August 2020, we also reported a new genotype, the A23.1, which had a lot of altered spike, a lot of mutations that worried us. These mutations were very much correlating with the variants of concern and variants of interest, and we were concerned that this strain could spread and cause more severe disease. But this did not happen. This strain, of course, spread in the country, but also in other countries. Later, it was reported in the UK and in the rest of the world. We continued following the variants over the period of time. As I said earlier on, we had strains that were matching where travelers came from. The second wave, we mostly saw the A23.1. The third wave, Delta, was the most dominant, and currently we have Omicron. And here I've summarized the lineages of Omicron that we have. Of course, in the beginning, like many other places, we had the BA1 and BA2, as you can see on the graph on your left. But when you go deeper and look at over time, globally, there's been an increase in the BF.4 and BF.5, but I can see also looking at it, just glancing at this slide, is that we are also seeing a shift so that we are getting more. If you look at sequences, more recent sequences of June, July, August, September 2022, we are beginning to get a dominance of BA.4 and BA.1, replacing the BA.1 and BA.2. But more work needs to be done. Very much genotyping is currently going on. How about vaccine studies? Some of the earlier studies we made before the vaccines were introduced were to look at willingness to participate in the COVID vaccine trials, and surveys were done among health workers, and also knowledge, attitudes, and practices regarding COVID-19 health workers. I think that was the time when, of course, many individuals, including health workers, saw themselves at risk of getting COVID. They were really looking forward to vaccines, and the willingness was very, very high. And that gave us an indication that if maybe trials start, because at that time there were no vaccines, we hoped that we'll do some trials. At least that gave us an indication that it will be possible to do vaccine trials within the health workers. But also, there were attitudes, knowledge and attitudes among these health workers on COVID-19 was generally high, which was a good indication. We are currently participating in 3 COVID vaccine trials listed here. Of course, there are other groups in Uganda participating in other studies. We're participating in the Sanofi vaccine study. For those who know this trial, it is a 2-stage trial. using initially a monovalent vaccine that is based on the D614 strain, and then a multivariant stage 2 that includes the Delta. I know that Sanofi has moved forward. Our studies are moving forward, but Sanofi has indicated that the multivariant vaccine, I think, can be used as a boost in those who have received other vaccines. We also have another vaccine trial being conducted, developed in Canada, that uses squalene in water as adjuvant, but also using a Wuhan strain to see its effect in our population. And it's manufactured by the Vaccine and Infectious Diseases Organization. And the last one is the self-amplifying ribonucleic acid. And I'd like to say a little bit more because we have been working with our colleagues at Imperial College on this vaccine. This trial is a non-randomized comparison in 42 individuals. Half should be seropositive for COVID, and the other half seronegative. LNP COVID self-amplifying RNA made in lipid nanoparticles. One dose is given at week 0 and another in 4 weeks. It's made by, developed by Imperial College, Professor Robin Shattock, and this is conducted at our site, the first self-amplifying RNA vaccine study. We are determining the levels of spike antibodies in these individuals who are pre- and post-dosing with this vaccine, the frequency of spike immunoglobulin IgG, the titers induced, and also looking at concentration determined by sequential use of sensitive and conventional ELISAs. So we have baseline data and post-vaccination visit. We have just analyzed this data, and I just wanted to briefly share with you what we see. So this graph indicates to you the levels, the OD values, and also of the spike and the nuclear among these individuals who have been vaccinated 2 doses, and they have been followed. Visit 2 should be the time of vaccination up to the last visit. I think what surprises you on the left when you look at the nucleoprotein, I would not expect those high levels, especially if this group has not been divided into seropositive at baseline and seronegative. But you see quite high nucleoprotein. Yeah. But you can see the spike is increasing over time, indicating to you that maybe the vaccine, indeed, since it has a spike, it is really leading to this increase in antibodies. But the presence of the nucleoproteins at baseline indicates to us that maybe many of these individuals were already infected. And one of the challenges, and we need to look at this, we had a very long gap between screening and enrollment, some more than a month. Although we had screened them as seronegative, they could have been infected during that period, and hence they have nucleoprotein. But we are going to unblind as we move forward to see among those who were seropositive at baseline. This is again to show you the concentration of the binding antibody spike. The earlier one was OD, and this is the concentration. Again, you can see an increase in spike, but also low levels of nucleoprotein, which possibly could be individuals who had been pre-infected. But the vaccine has some effect on increasing the spike antibodies over time. We have seen very low interferon gamma L-spot responses, and neutralization work is ongoing. So this vaccine, at least to us, it is interesting, a new concept of using self-amplifying RNA, which is slightly different from the messenger RNA of Moderna and Pfizer, because this is put in the Venezuela equine encephalitis replicase to amplify the RNA. How about immune antibody profiling? We're interested in seeing how antibodies develop over time in the individuals who are infected, data that was very limited within the African setting. That will allow us to improve our understanding of the anti-COVID-2 protective immunity, evaluate virus-specific antibody interferon gamma dynamics, durability, and correlation with disease outcome. And a total of about 320 PCR confirmed mild and asymptomatic individuals were enrolled. They were followed initially weekly for 1 month, and then monthly up to around 29 months. So it's a very long follow-up. And they were quantified and correlated with demographics, clinical presentation, and whether reinfected or not. A busy slide, but the take-home message here is that we saw a slightly higher levels of IgG, IgM in individuals who had no symptoms compared to those who had symptoms. Of course, in some of the isotypes, there's some significant difference. But you see slightly more of these antibodies in individuals who are asymptomatic compared to those with mild disease. Again, this is a busy slide just to give you the trend of the antibodies over time. We see a peak of IgG around 24, 27 months, days. Very low, IgM is lower, but we see a persistence of IgG and IgM. And of course, over time, the numbers reduced, but we were surprised to see that these antibodies continued. If you look at the whole cohort, it gets very confusing because in the 320 individuals, later you'll get individuals who are reinfected, individuals who are vaccinated, so it gets complicated. And we had a way of identifying individuals with no reinfection. And we did this by looking at individuals where we confirmed reinfection by PCR and see the trend, the dynamics of antibodies. We see a rise of nucleoprotein antibodies in those who are reinfected, and this was also confirmed in another publication. So we were able at least to identify individuals with no reinfection and no vaccination, and again we see a persistence of antibodies over time, which indicates that these antibodies can remain. But of course, we don't have functional data to show whether these antibodies are really functional in terms of neutralization. Now, if you look at individuals who, the earlier one was, the earlier slide was spike, and then this is the nuclear protein. But if you look at individuals who have been reinfected, again, it may not be clear to you, but I want to convince you that they have higher antibodies and there's higher persistence, indicating that reinfection does benefit in terms of raising your antibodies levels and persisting a little bit longer. We are using this cohort through funding from the Bill and Melinda Gates Foundation to understand neutralization, broadness of neutralization, to identify, to contribute to monoclonal antibody discovery among these individuals. I think capacity that will allow us to do further work as we move forward. We have also looked at individuals who have been looking at pre-existing immune responses, because one of the prepositions why severity of disease was low in Africa, could Africa have had a little bit more pre-existing antibodies to SARS-CoV-2 and to other common coronaviruses, and we have done some work. What we see is that these individuals, pre-COVID, samples that were collected pre-COVID, actually, they don't have T-cell responses specific to SARS-CoV-2, but to some of the common coronaviruses. And here you can see responses to 229E, common corona, but none of responses to other. We look at the antibodies again, pre-COVID earlier on. Here we saw a lot of nucleoprotein in these individuals, and also S protein, showing that there could have been cross reactivity. But we went further to do neutralization, and all these individuals who were pre-COVID did not have any neutralizing antibodies, although they had binding antibodies to some of the spike and nucleoprotein. indicating to us that if there's no neutralization activities pre-COVID, the preposition that probably in our African setting we have a lot of pre-existing neutralizing antibodies may not really hold water. The limitation, of course, we have not done antibody-dependent cell-mediated cytotoxicity, which could also be related to the binding antibodies that we have seen. We have also been, through the encouragement of government and the president, looking and developing, constructing some vaccines, working on inactivated vaccine and adenovector vaccine. To me, I think what I like about this is developing the capacity. We may not have a vaccine for COVID, but in future we may have relevance. This capacity could have relevance in addressing some of the future pandemics, especially that are relevant. A colleague who is working on inactivated vaccine has made the protein, has purified it, is very clean. This is the spike. She's putting the adjuvant, soon going to animal studies. The colleague who is working on the adeno was able to identify very unique chimp adenoviruses. She has been able to insert the spike, including removing the E1 region, which could be pathogenic, and she has gone on further to show that this construct is very well expressed, and also has done studies to show that this chimp is not pre-existing within our population. One of the challenges of using the adenovectors, because you want to use those that are not where you don't have a lot of pre-existing antibodies. In my final slides, I want to talk about the Ebola outbreak. As you know, in Uganda now we have an Ebola outbreak since September. You are aware that we have about 5 different Ebola virus strains: Ebola Zaire, Ebola Sudan, Ebola Bundibujo, Thai Forest, and Reston. In Uganda currently we have Ebola Sudan. Ebola Bundibujo actually was isolated first in Uganda. Due to the limited amino acid homology in the glycoprotein across the Ebola viruses, there is no, unfortunately, cross protection. And that's the challenge that we have, that the vaccine that was used for Ebola Sudan, Zaire, cannot work for Ebola Zaire. This is, I think, 2 days old. I was not able to download the latest, but you can see the confirmed cases by that time on the 5th, reported 5th, but I think that is data of the 4th. We had a total of about 132 individuals. There's controversy in Sudan, at least in animal studies, that is the where it has been lower than expected. Initially, we had individuals who died who had not been confirmed, but the picture shows these had also Ebola. And you can see the trend of Ebola over time. Ebola that we had in 2011 in the same country. So one of the questions, where does Ebola hide? Because the strain that we have, all this, what I'm showing here is Ebola Sudan, but this, where does it hide over the period? Understanding the reservoir of Ebola is a very important research question. We have also done more sequencing, and we can see 5 main clusters identified from. You can see the major outbreak was in the area called Mubende, and as you can see, a lot of the other Ebola cases that, is it purple or what? The bigger one, the bigger cycle. So there's a lot of Ebola is being transmitted. We are now planning ring vaccination study. This is a cluster randomized trial, recent contacts of newly confirmed case of Ebola Sudan against laboratory confirmed cases. We don't know yet which the case of Ebola Sudan, so it may well provide useful information about protection of such cases quickly. We may use either the Sabin vaccine, which is a chimp adeno 3 platform, the Chadox one as used in West Africa of doses. But some of these may be at 8% have completed primary series, but we did not see sublineages before self-amplifying RNA. We are looking at individuals that we collected before COVID, monoclonal, and currently the mortality is about 38%. I've been participating in these studies.
Pontiano, thank you. And colleagues in Uganda, and all strength to everyone. Yeah, in the front row there.
Thank you very much, Professor Kalebu, for the very insightful presentation. Your presentation really highlights the very important benefit of investing in research and development for other diseases, and you being able to implement studies quickly. One thing that struck me here is those increased mortality associated with increasing age, but not with comorbidities. And he highlighted that the only association was the reactivation of the gamma herpes virus. To me, this is very striking and really shows the need of having contextualized regional studies. In your setting, what do you think could be different? Why do you think you're not observing that correlation with comorbidities, even in the older age group? My second question is on what was again striking on the willingness, knowledge, and attitude to taking up of vaccine studies. In your situation, it's excellent. Could this be due to the sensitization to other vaccine studies? Thank you very much.
Okay, indeed, it is surprising. I would have expected the association of COVID patient. Probably we need to do larger studies. Some of these studies, I think one of the limitations is the size of the study, including associations with HIV and other co-infections. We need to do larger studies. We need to do multi-center studies. We need to general population. We did not see that, but I can tell you there's another study I'm aware of that indicated there was some association with comorbidity like hypertension. But the rest of the studies, I think, suffer from that power in them being a little bit surprised. Yeah. Yes. The willingness to participate could have been these health workers perceived themselves as being at high risk for COVID available. And there was a lot of advocacy. Some wanted to see that there was that perception of being at risk could have contributed to this.
Thank you for that. One is heading your way. Who is it? Is it Martin?
So, thank you very much, Tiano, for a very interesting talk. I have 2 comments. I was really excited to look at based vaccine that could be used locally, not just in East, but also in West Africa. So it's really quite exciting, and I would like to congratulate yourself and the team for leading that effort. My main question is about the nomenclature for Ebola, actually. So we are Sudan strain. Now, my grandmother might think that this outbreak is actually occurring in Sudan. So the serious question is that, are we thought about changing the nomenclature for Ebola just like it's been done for COVID-19? I think this is critically important. And if the African Union, we can all contribute. All right, so thank you.
Sorry. I'm struggling to hear, I'm sorry.
I'll be interested to know if we are thinking others. Are we going to use a neutral? Ebola may have been detected in the past. Thanks.
Sorry.
Was it a question? Sorry.